And welcome to Wonderful Wednesdays, SvO2 and what it can do for you. So let me share my screen and we shall begin. So I always think it's so incredibly important that we have a good understanding about SvO2 or ScvO2, just depending on where you work and what catheter you have. So when I refer to SvO2, I'm always talking about a PA catheter. And when I'm referring to ScvO2, talking about a central catheter that is in the SVC and what that information can do for you and your patient too. So really important to just start off with a basic explanation. We're going to look at a lot of information, but it's going to be so straightforward and exciting. So SvO2 is the amount of hemoglobin that are saturated with oxygen measured in the pulmonary arterial circulation. So that is what we call SvO2. That blood is mixed venous, meaning from the SVC, the IVC, the coronary sinus, the thespian veins, all the veins draining blood back into the right atrium, mixing in the right atrium, mixing the right ventricle, and ejected up into the pulmonary artery. So what's so important for us to appreciate about the SvO2 is that it is a very excellent measure of what the total body is using in terms of oxygen. ScvO2 is an indirect surrogate, and it's good as long as patients are not hyperventilating, as long as they don't have a rapid heart rate. If they've got a rapid heart rate, they're hyperventilating, then it becomes a little less meaningful and less predictable. Now, the normal range for SvO2, that's the venous gas, the venous sample drawn from the distal lumen of the PA catheter. The normal range is 60 to 80%. That means 60 to 80% of the hemoglobin are saturated with oxygen. And whatever you send out, 95% or 100% saturation, that's what's been used by the tissues. And that's going to be referred to throughout this talk as oxygen extraction. Oxygen extraction is the percent of oxygen that the tissues use. Now, that's not to be confused with something else that people talk about, which is oxyconsumption. And we're going to look at both of those and what the meaning of them is and how easy it is for you to understand it and use it to guide therapeutic intervention and to promote discussions with your colleagues about what needs to happen for your patient. Now, the thing about SvO2 is that that's going to go up and down and up and down a lot. Every second it changes. I coughed, it goes down. I turned, it goes down. I am happy to see my husband, and it goes down. SvO2 is very variable. So is ScvO2. It's always associated with spontaneous fluctuations. Now, fluctuations are typically less than 5%, and they recover very quickly. So that's quite important because when we see that SvO2 goes down 10%, 12%, 20%, and doesn't recover for 5 to 10 minutes, that really tells us that we have a patient who is at risk. More on that a little bit later. So in general, when we are monitoring SvO2, what we will say is that it must exceed a 5% change and persist for longer than 5 minutes to be considered significant and perhaps requiring intervention. A change in SvO2, and that's with continuous monitoring, a change in SvO2 with continuous monitoring must change more than 5% and persist for longer than 5 minutes for me to consider it significant and for me to wish to do therapeutic intervention. Oh, that's a relief for us because if we're the people at the bedside monitoring SvO2, it's going up and down and up and down. We'll just be crazy if we don't actually say it's got to change more than 5% for more than 5 minutes before I'm on the phone asking for an intervention. Now, probably based on who's on this call, I'm not positive, but I think based on most of the folks who are on this call, you are not using PA catheters. You do have central lines. Now, with your central line, you have the capability to actually place a central line that allows you to continuously monitor ScvO2 or you place a central line that allows you for an intermittent draw of a blood gas to send off to the lab and to measure ScvO2. In either case, I mean, I think one is better than the other. Personally, I always want to be continuous. My grandbaby walks for the first time, a still photo, 1 second in the time of him walking is not nearly as meaningful as a video. And that's exactly the same when we talk about ScvO2. Now that is requiring that you have a central line in the superior vena cava, and we're actually monitoring it continuously with a specialized central catheter or intermittently with a central catheter. And we're going to call this central venous oxygen saturation. That's what we see when we talk about the superior vena cava. Now, this is a lovely indirect surrogate or an alternative to the mixed venous O2 sat because it eliminates the need for a PA catheter. And that normal range for the ScvO2 is actually, I'm so sorry, I'm hoping that this is actually the right talk. So let me just be sure. I think it is. I made a couple of changes, but I need to change this right now. The normal ScvO2 is 65 to 85%. Now that's different than the SvO2, which is 60 to 80%. So it's a little bit different. It's a little bit higher because the central venous sat doesn't incorporate the coronary sinus. And remember, the myocardium is using a lot of oxygen. So depending on your SvO2 or your ScvO2, the normal oxygen extraction is 25% to 30% versus the normal SvO2, which is typically going to be 60 to 80%. I'm sorry, 20 to 30%. This is indeed the wrong program. So let me just make sure I've got the updated one. Sorry about that. Looks like it is the updated one. So I must have just messed up and not saved my changes. So very good. I'll just go right back to it. So sorry, because I want to be sure I'm giving you the most up-to-date information. Okay, so now I just want to remind us all about oxygen and to remind everybody that dissolved oxygen exerts pressure. That's the P in PO2, PaO2, PVO2, right? That's the P, exerting pressure. So you have a partial pressure of oxygen in inspired air, and that partial pressure at barometric pressure is 748, that's sea level, living at sea level. That FiO2 of 21% equals about 150 to 160 millimeters of mercury of oxygen. That's what I'm breathing into my alveoli, and I lose some of that partial pressure as oxygen descends the conducting airways, and now it gets to the alveolus, and in the alveolus, it's 100 to 110. Now, when we think about this perspective, we just want to remind ourselves that this is affected by your FiO2 and, of course, by your alveolar capacitance. Okay. Now, once we get down into the alveoli, that partial pressure is going to determine what occurs in the arterial blood. So very important to remember that I have a lot of oxygen in the alveoli, and I have some oxygen that's dissolved in the arterial blood, but most of the oxygen in the arterial blood is bound to hemoglobin. And that's what we call SaO2. So a very small amount of oxygen is dissolved and usable, and the majority of oxygen is bound to your hemoglobin, and that's what exerts your SaO2. Now, what's going to happen is that when we look at the capillaries, the amount of oxygen in the capillary, 50 to 80, is always about maintaining a constant oxygen level in the tissues. So oxygen is released from your hemoglobin depending on the amount of oxygen that is needed to be dissolved to maintain tissue function. And it's released from the hemoglobin dependent on what the tissue demand is and how much oxygen you actually delivered. So very, very important for us to appreciate. I can't see this. All I see is SaO2. I don't see how the oxygen is released unless I'm doing SvO2. And I don't really see whether or not I have to actually affect the delivery of oxygen or the demand for oxygen. All I want you to remember is the role of hemoglobin bound to oxygen is to release oxygen so it can dissolve in the blood, so it can go to the tissue, so it can ultimately go to the mitochondria and be used by the cells. So if my cells are hypermetabolic, they're going to consume a lot of oxygen. They get more oxygen from the tissue, and the tissue gets more oxygen from the capillary blood. And the capillary blood gets more oxygen because the hemoglobin has to release it. Now, you can see there's a big difference between the arterial dissolved oxygen and the venous dissolved oxygen. This is pre-capillary, arterial, and this is post-capillary, venous. So really profoundly and significantly important to remember that the way we evaluate this in general is we look at SvO2 or ScvO2, which tells us how much oxygen remains bound to the hemoglobin after cellular use is complete. The more hypermetabolic the cell, the more oxygen will be consumed, the more the hemoglobin will have to release oxygen for it to be used by the cell. Okay. So that takes us to a really, really, really important concept. And I use this slide a lot. I developed this just basic strategy of explanation like 15 or 18 years ago. I've manipulated a little, but not that much, just to remind you that the number one issue of maintaining your oxygen is to enforce an appropriate cardiac output. Now that your patient does that himself by increasing his heart rate, and you do that by increasing his stroke volume. You give volume, you give inotrope, you want to increase the deliverer of oxygen, cardiac output. You also have to always consider the carrier of oxygen, which is hemoglobin. So by the way, whenever you see an SvO2 of less than 60%, that goes for central venous or mixed venous. I'm just going to say SvO2. Sometimes I'll say ScvO2. I'm meaning the same thing. Whenever it's below 60%, you have two requirements. First, you have to evaluate if the patient is actually acidotic. And if he is acidotic, the very first thing you're going to do is you're going to increase your patient's cardiac output with volume and inotrope. And then number two, you're going to consider increasing oxygen carrying capacity. So remember, if SvO2 is less than 60% and the patient is acidotic, you will increase their cardiac output and you will increase their hemoglobin. Now, if they're not acidotic, you will probably increase their cardiac output, but you won't necessarily increase the hemoglobin unless it's less than 8. The least important component here is the saturation of that hemoglobin in the arterial bed. Typically, we say if you're greater than 88% saturated, you're doing okay. Now, what we want to remember is when your tissues are requiring a lot of oxygen, the first line of compensation, which is employed by the patient, is to increase the heart rate and venoconstrict, returning more volume back to the heart in order to increase the delivery, the cardiac output. So increasing that stroke volume, increasing the heart rate, therefore increasing the cardiac output to try to improve delivery of oxygen to the tissue level. Now, your patient can't increase his total hemoglobin. You have to help him with that. And typically, they cannot increase their saturation of their hemoglobin. You have to help them with that. But they, by themselves, will attempt to increase their cardiac output through the increase of the heart rate and the venoconstriction, reabsorption of water at the kidney to increase the stroke volume. If that's not adequate, you have to help them with that. You have to give them volume. You have to give them inotrope. You don't really want the heart rate to be up because that's an inefficient way of increasing the delivery of oxygen. Now, if you're standing idly by let's just say that for 5 hours last night, you were monitoring SvO2 and charting that it was 55, 56, 58%, that's below 60. And your patient had metabolic acidosis heralded by a base deficit of -5, -6, -4, and you did nothing. You did not increase his cardiac output, even though you already knew he was consuming a lot of oxygen, because that's why his SvO2 is down, and he has an inadequate delivery. So you're putting your patient at risk when that occurs. So we have to pay a lot of attention to these numbers. They are just numbers, but they are part of a profile that tells us what's occurring. Now, we didn't do anything for the patient. Let's just say we didn't do anything. He had a 58% SvO2. We didn't give him volume. We didn't give him inotrope. We weren't really worried too much about it. And I want to tell you, the reason that his SvO2 was 58% is because he went to a second and rather inefficient form of compensation. He did that himself. You didn't have to do it, okay? And what that inefficient second compensation is that the hemoglobin releases more oxygen. Now, remember, the amount of oxygen your cells need changes every single second. But when your demand or consumption increases, your hemoglobin is going to release more oxygen. That's known as a shift to the right release. That means when you look at the SvO2, it's gone down because they released oxygen. When their demand or consumption increases, the hemoglobin will latch on to the oxygen. That's called a shift to the left. Now, what's really important for us is, first and foremost, when we see a shift to the right, we always step back and say, you are behaving inefficiently, and I need to increase your delivery. I do that by cardiac output, heart rate, stroke volume, and inotrope. I might consider giving you hemoglobin, and if necessary, I'll try to increase your SAT, but I'm not going to do that as a first line defense. First, I'm going to give you volume and inotrope, and then I'm going to consider red cells. Lastly, I might improve your arterial SAT, but only if it's less than 88%. Secondly, I want to decrease the demand your tissues have for oxygen. I want to decrease the demand your tissues have for oxygen by treating fever, by treating pain, by treating agitation. Those are basically the things I do to reduce your tissue demand. And I also have to be sure that as best as I can do, I want to maintain your blood flow through all your capillary beds. So I'm going to try to do that. I might not be able to, but what I'm going to use is my SvO2 and my indicators for metabolic acidosis to tell me when I've made that better or when I've made it worse. And sometimes in the attempt to make it better, we indeed make it worse. Okay. So I want to remind you that PaO2 is usable gas. Gas has to exert pressure to mobilize across the endothelial surface of the vessel and into the cell where it's used at the mitochondria. So you must have dissolved gas, must have dissolved gas. And hemoglobin releases that bound oxygen, known as the shift to the right, when your cells need it and when your cells can get it. Hemoglobin latches onto oxygen, known as the shift to the left, when your cells don't need it, you don't have metabolic acidosis, or when your cells cannot get it. Okay, so really, really important for us to appreciate here this simple cartoon that I use in every lecture I give, where I divide between the oxygenated and the relatively deoxygenated blood. So you can appreciate that SvO2, whether it's central venous or mixed venous, is after the cells have used their oxygen and before the blood passes through the pulmonary bed and reoxygenates. Arterial blood means the blood that has passed through the pulmonary vascular bed and reoxygenated and before it reaches the cell. So when you look at an SaO2, that tells you one thing only. And it's really important to remember that. It tells you about lung gas exchange. It doesn't tell you about tissue gas exchange. It tells you about lung gas exchange. And it tells you about what's available. But SvO2 or ScvO2 That tells you about what the tissues used. And this is vitally and profoundly important because it guides all of our interventions in critical patients. Now, we talk about this as a curve, and that curve is referred to as the oxyhemoglobin dissociation curve. Okay, so what? All it means is you have oxygen bound to hemoglobin. That's 98% of all the oxygen in the blood. I'm not talking about 98% saturation. I'm saying out of all the oxygen in the blood, 98% of it's bound, which means it's not usable. It has to be released from the hemoglobin to dissolve in the blood so it can be used by the cell. That's a tiny amount of the oxygen. So hemoglobin bound to oxygen is very sensitive. As the cells use more oxygen, the hemoglobin will release oxygen, meaning that it will start to desaturate so that oxygen can be used by the cell. Okay, that's what we talk about when we talk about an oxyhemoglobin dissociation curve. So I can almost guarantee you that on your CEN, your TCCN, your PCCN, your CCRN, your CNS, your APP exam, they always talk about oxyhemoglobin dissociation in the arterial bed. And you know that because you're looking at percent saturation, 90 to 100, and dissolved oxygen, 80 to 100. That means arterial. The problem is this doesn't have any meaning to you. You care about this because it tells you about lung gas exchange, but it doesn't have any meaning to you as it relates to the tissue. Now, what we talk about is this critical level where below this, below a dissolved state of 50, you will rapidly release oxygen. But that typically isn't happening in the arterial bed. So very important to remember that when we talk about oxygen dissociation, here we aren't talking about dissociation, we're talking about association. Association is how much oxygen is bound to the hemoglobin in the arterial bed. When we talk about dissociation, we're actually talking about the venous bed. Now, when you take your exam, it's always about the arterial bed, so that's good for you to know. But clinically, it's really important to remember that the role of your hemoglobin as it moves through the capillary is to release oxygen so it can be used at the cellular level. So you will always have a shift to the right. A shift to the right means oxygen comes off the hemoglobin, dissolves in the blood so it can be used by the cell. The more the cell needs, the more you will dissociate and your number will go down, 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 and down. Now, that's a lovely thing, except that when your number goes down, your patient is now at risk for ischemia and infarct of all cells and all organs, brain, heart, diaphragm, muscles, kidney, mesenteric bed, spleen, and liver. When that number goes below 60, what it means is you are aggressively releasing oxygen from hemoglobin because your cells need it. And the number one therapy is to increase the delivery, not to a cardiac output number that's made up on your monitor, but until your SvO2 normalizes and you obliterate acidosis. I can't tell you how important that is. So there's a couple of concepts that people talk about a lot. I don't know that it's essential for you to know all the calculations. I can give them to you. I do them all the time. And I know them off the top of my head because I've been doing this for a really long time. I'm very interested in tissue oxygenation, but it is important to just have familiarity. So first of all, you see the letter A, that always means arterial. Capital C, AO2 is content of arterial oxygen, which is a calculation of total oxygen based on oxygen bound to hemoglobin and dissolved. So that would be your SaO2 and your PaO2. Central content of venous oxygen, C, big C means content, and of course V is venous. The amount of oxygen that is bound to the hemoglobin and dissolved in the mixed or central venous blood. So your SvO2 and your PVO2, that's all. No one's asking you to calculate it. You put your numbers into your bedside monitor, it'll calculate it. You put your numbers into your flow tracker, your EV1000, it will calculate it for you. You don't need to calculate it. Now that content just means how much oxygen is dissolved in the blood and bound to hemoglobin. Not that meaningful. What you actually have to do is deliver that. So the delivery of oxygen in the arterial bed is content times cardiac output, which tells me how much oxygen I'm delivering to the microcirculation per minute. DVO2 is the delivery or the return of the oxygen to the pulmonary circulation in mLs per minute. Pretty easy, right? Ca yields Da, Cv yields Dv. And the difference between Da and Dv is the amount of oxygen the tissues utilized. Okay, so a lot of times our docs will talk about oxy consumption. That's what this is. They also use the term oxy extraction. These are not the same thing, although oftentimes they refer to them. Oxy extraction is a proportional use of oxygen as it passes through the microcirculation. So that's what O2 O2 extraction ratio is. Now, don't get worried about this. This is my design to help people understand this. So you can see all the way down on this side, you have the letter A, the letter A, the letter A, SaO2, amount of hemoglobin saturated, CaO2, amount of oxygen carried by the hemoglobin, and DaO2, the amount of oxygen delivered to the cells, all in the arterial bed. Over here in the blue, you have SvO2, CvO2, and DVO2, amount of hemoglobin saturated with oxygen in the venous blood, the amount of oxygen carried by the hemoglobin in the venous blood, and the amount of oxygen delivered back to the right heart to go into the pulmonary circulation. There are only two formulas. And again, I'm not asking you to know these formulas. I'm really not. I want you to understand the concept. You have to know what the arterial sat is, and you have to know what the hemoglobin is. That's what gives you the content. You have to know the cardiac output. That's what gives you the delivery. You have to know what the SvO2 is, and the same hemoglobin, and the same cardiac output. So the only two different numbers that you are looking at are SA and SV. So by the way, consumption, the easiest thing to do at your bedside, easiest thing to do, don't have to have a measurement for cardiac output, is just to look at consumption, which is VO2, that's consumption per minute, and take SA minus SV. That's going to tell you about consumption. If I want to look at extraction, it is SA minus SV divided by SA. So this is your consumption level, and this is the proportional amount that you are using. Extraction goes up, it increases in a poor blood flow state, and it decreases in a microcirculatory obstruction state like sepsis, like volume overload. So really important for us to understand these. I'm trying to make them as simple as possible. All you need is an arterial gas and a central venous gas. They have to be drawn at the same time. You take SA minus SV, that's going to give you percent consumed. You take SA minus SV divided by SA, that's going to tell you about proportional extraction. And proportional extraction tells you when you need to increase your cardiac output, meaning you got to give volume, you've got to give an inotrope. Proportional extraction will also tell you when you need to give pack cells. It's so straightforward. And by the way, it should change the way you are treating patients. And it's so simple. All you need, same time drawn, central venous gas and arterial gas, take SA minus SV, and then take SA minus SV divided by SA. So you do this one first, and then you just divide by SA, and now you have percent consumption. You're not going to have it in mils per minute when you do it this way. You'll have percent consumption and percent extraction. So I can have a patient who is consuming very little oxygen, but proportionately it's a large extraction. So it's very nice that actually these numbers tend to be about the same. Consumption percent, 20 to 30%, Extraction ratio, 25 to 35%. Anything above 35 means your patient is dissociating oxygen from their hemoglobin at a rapid rate. Shift to the right, shift to the right, shift to the right, release, 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 because your cells need oxygen. And if you allow them to persist in that state, they will infarct the endothelial wall, and now you will not be able to restore them to normal blood flow states. That's what happens. That's why we have to have a higher degree of understanding of this information. Okay, so remember, shift to the right. Hemoglobin has less affinity to oxygen. It releases the oxygen because your tissues need more oxygen. That happens in an acidotic environment. You've got a high temperature, you're hypermetabolic, right? Very, very important. Acidosis is the biggest determination for the releasing of oxygen from hemoglobin. So again, I'm going to have acidosis. I'm going to release oxygen from hemoglobin. My SvO2 is less than 60%, but I have a base deficit that's -4, -5, -8, -10. I have a wide anion gap, a low bicarb, whatever you're using to look at metabolic acidosis. And it ain't pH, by the way. So it's got to be either and all three. Bicarb decrease, base in deficit, or a wide anion gap. You got to look at that together. You can't look at it alone. Shift to the left means that hemoglobin doesn't release the oxygen as much. And it might not release the oxygen because your patient doesn't need it, or it might not release the oxygen because your patient needs it, but they can't get it because they have a blood flow dynamic. So again, what does this all mean? SA minus SV is normally 20 to 30%. An increase in that difference, greater than 30%, means that you are not delivering enough oxygen to maintain tissue function. It doesn't matter if the cells are hypermetabolic, your patient cannot compensate with an increase in cardiac output. He needs volume, he needs inotrope, and he might need red cells. Volume, inotrope, red cells. Yes, give vasopressors if he's hypotensive, but that doesn't actually make him better. That makes you better. It doesn't make him better. You need to know what the problem is. If you have a difference that is greater than 50%, the probability is this patient is not going to survive and he's going to infarct all his endothelium. Now below 20%, so remember normal is 20 to 30, above 30 means you need to give more delivery. That doesn't mean you give the patient more oxygen. It means you give him a better delivery. Cardiac output first, hemoglobin second, sat last. You're going to decrease his demand, control temperature, pain, and anxiety. So what you're trying to do is get him back to a normal ratio, but more importantly, you're trying to get him back to the absence of metabolic acidosis. So a decrease in SvO2 below 20% might mean you did a great job, but you don't know that until you look at whether or not the patient has acidosis, because a decrease in the SA minus SV below 20% in persistence with metabolic acidosis means that you now have a problem using oxygen at the cellular level, and you're shunting from artery to vein without releasing oxygen. I'm going to tell you that the most common reason that that occurs is because you're using aggressive vasopressors. So as you use aggressive vasopressors, you shift arterial blood to venous blood without the movement of that blood through the capillaries. So I might start off with a patient who is relatively hypotensive with a SvO2 of 52% and a base deficit of -5. And I'm titrating up and up and up on his norepinephrine or his epinephrine or both. He's got vasopressin, but I don't titrate that. I'm titrating up and up and up and up. And all of a sudden now the trend of my SvO2 or ScvO2 is going up. But the patient has gotten more acidotic. His base, which was -4 or -5, is now -8. And that's because what you've done is created an AV shunt. That's why we have to be really careful about the administration of vasopressors and use a much more thoughtful mechanism when we're applying them. Vasopressors are great, don't get me wrong, but they need to be done and managed appropriately. Okay, so if SvO2 or ScvO2 is lower than 60, or the difference is greater than 30, always, first and always. I don't care if you're at the bedside measuring the cardiac output. You're like, well, Barbara, it's a normal cardiac output. A normal cardiac output is the one that supplies enough oxygen delivery to the tissue that you don't need to use oxygen from your hemoglobin reserve. So by the way, it's great to memorize a normal value so you can pass a pen and paper test or a computer test. But on caring for the patient, if the SvO2 or ScvO2 is down, first, always, 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 you need to increase the cardiac output. And you're going to do that with fluid and inotrope. So right now we have a CT surgeon who I am very pleased to say really pays attention to these numbers and wants us to manipulate the patient. If the SvO2 is down, she wants that patient to get fluid. She wants people to go up on inotropes to get the SvO2 to normal. Now, it can't just be the SvO2. It also has to be the absence of acid. So the first thing you do, no matter what the measure of the cardiac output is, nobody cares what that measurement is really. We just want you to increase the cardiac output because that's the deliverer of oxygen. All right, so you're not using a PA catheter, you're in the ECC, you got a central line, your SvO2 is 40% and your patient's heart rate is 128. Your goal is to increase their stroke volume. So you're going to give them volume, you might give them some low dose inotrope. And what you want to see is that the next ScvO2 you measure has come up to normal. Now, the problem is that when you're doing it intermittently, you can't really measure quite as well what you're doing. And what that also means is you can't do one SvO2 in the ECC with a critical patient in shock, and it comes back at 45 and you do all sorts of interventions, but you never measure the SvO2 again. You should be measuring the SvO2 every hour. After every significant intervention, you should measure SvO2. Is it costly? Yes. Is it as costly as 8 days in the ICU and then dying? No, it's not. So we got to kind of get past the cost of the blood gas and understand the human cost and the long-term cost of being in an ICU bed for a long period of time. After I treat there, I'm going to consider hemoglobin. I'd like to always be sure that you have enough hemoglobin to carry oxygen. Typically, that means you should have a hemoglobin of close to 10. I would never give packed cells to somebody whose hemoglobin level is 8, who has an SvO2 of 72% and has no metabolic acidosis. They don't need hemoglobin. They only need hemoglobin when they have the presence of metabolic acidosis because they're not carrying enough oxygen. And then last but not least, I'm going to try to control the amount of oxygen that you're asking for. That demand is too high. So I'm going to consider controlling your fever, your pain, your agitation. Now, I don't do that as a separate measure. I do that in conjunction with fluid and inotrope. I do that in conjunction with packed cells and whole blood, because what I want to see is your SvO2 comes up and the difference reduces. The difference reduces to less than 30%, and that you no longer have metabolic acidosis. So really, truly, when we're looking at SvO2 or ScvO2, remember that intermittent's not as valuable as continuous. It still has a lot of value. My patient drops his pressure and his heart rate goes up. I've got a central line. I'm drawing an ScvO2. I'm not just drawing it because someone asked me to. I'm drawing it because I know it needs to be done because it tells me about tissues at risk. If my SvO2 is down, and again, remember, I use that universally for both SvO2 or ScvO2. If that is down, that always means my tissues are at risk. And if it stays down, so I'm going to increase your cardiac output, I'm going to give you hemoglobin, and I'm going to reduce your demand. If my SvO2 is normal or elevated, it may mean my patient's doing great. Maybe I over-resuscitate him. Maybe his condition resolved, and how happy are we with that? But we can't know this without also correlating metabolic acid levels. So it can also mean when I have an increase in SvO2 is that I've got a worsening clinical condition. I have a microcirculatory deficit. I've got to correlate that to metabolic acidosis. So in conclusion, I'm just going to remind you, when the delivery of oxygen is inadequate, delivery of oxygen is cardiac output and oxygen carrying capacity, hemoglobin, cardiac output and hemoglobin. When that's inadequate, the patient who has an increased demand will actually stimulate the release of oxygen from hemoglobin, causing a shift to the right. And that risk, when we release to the right, is that the patient will have significant organ ischemia. This occurs when demand is high, cardiac output is poor. And by the way, not by numbers, guys. You wrote some number down, which was wonderful, from your flow track or from your hemisphere or from whatever way you might be measuring cardiac output. And that number looks fine. But if I have a patient who is dissociating oxygen from his hemoglobin, and I measure that with the SvO2, that is not a good cardiac output. Doesn't matter what the number is. It could be 8, it could be 4, it could be 2, it could be 12. If I have a patient who is rapidly dissociating oxygen from hemoglobin, that means SvO2 is down. My patient needs me to support first their cardiac output and secondly, their hemoglobin. So again, fluid, inotrope, red cell. When delivery is adequate and the cells can use oxygen, you're going to have a shift to the left. Okay, but I can only know that if I do an acidosis check, not just lactic acid, but metabolic acid. Cells demand less, so less oxygen is needed. So the hemoglobin doesn't need to release it, it hangs on, but it always has to be validated when you have an SvO2 of normal or elevated, needs to be validated with the clinical condition and the absence of acidosis. And here's the one that's the most difficult. Delivery appears like it's adequate, and your SvO2 is shifted to the left. The patient has acidosis, that's not adequate. Your patient requires vasopressors, that's not adequate. Your patient's on CRT, that's not adequate. So in this condition where your SvO2 may be normal to elevated, but you have worsening acidosis, increasing requirements for vasopressors, or the patient now needs to go on CRT, but your SvO2 is normal or elevated, you have to look at the presence of acid. Here, your cells cannot utilize what's been delivered. You have an AV shunt, blood doesn't flow through the capillaries, oxygen doesn't dissociate, your SvO2 is higher than expected. By the way, whenever you have acidosis, whenever you have metabolic acidosis, your SvO2 should be low. That's the normal range of compensation. If the cells are acidotic, your SvO2 should be low. If you're acidotic and your SvO2 is normal, something is really wrong, and that's typically a microcirculatory deficit. So I want to remind you, the delivery of oxygen and the proportional use of oxygen from your hemoglobin are inverse. As delivery goes down, hemoglobin releases more. That's the O2 extraction ratio. Remember, that's SA minus SV divided by SA. Normally, you maintain your oxy consumption as relatively constant over a lot of variabilities in delivery. But what's really important to remember that if I'm looking at these numbers and you start to see a decrease in the difference between SA and SV, and you have the presence of metabolic acidosis, this is a really significant issue. Now, what does that mean? That means when I look at SA minus SV and the number is less than 30, if I have no signs of tissue hypoxia, as measured by metabolic acid, lactic acid, decreasing base, decreasing bicarb, widened anion gap, I don't need to really treat my patient. I'm just going to observe, and I'm going to do that continuously or rapidly, intermittently. I'm not going to walk away from the bedside and say, all is right with the world this hour. And then I come back later and the patient's heart rate's gone up 15 points and you quadrupled the vasopressor. Something happened. And the best answer that I get is when I look at comparison of SA to SV and the presence of metabolic acid. It really changes the way we practice. So this very simple cartoon just reminds us that we don't really measure hydrogen ion, which is metabolic acid. But as that goes up, you will see the reduction in base and the bicarb will drop. The pH may also drop, depends on if the patient's compensating. What's really important is the gap gets wide, the lactate level usually goes up, and your SvO2 may be up or it may be down. If it's down, you're going to use fluids, inotropes, and red cells. If it's up, you're going to appreciate that you have a microcirculatory deficit. And most likely, so when your SvO2 is up and you're profoundly acidotic, but your SvO2 is up, means you've got oxygen, the cells aren't utilizing it. The only thing you can really do at this point is try to narrow the interstitial edema by using dialysis or diuresis, and by gingerly, and I mean gingerly, reducing vasopressor. A successful aspect when you reduce a vasopressor is you start to see the SvO2 goes down. What that typically means is you have now opened up vessels that you previously had closed with your use of vasopressors. So just consider this. Patient number 1, heart rate 141, you're already worried. SAT's 92%, but his ScvO2 is 70. Now you already know you can't answer whether that's normal or not. It looks normal because his SvO2 is 70, but he has a heart rate of 141. Why is that? Patient number 2, heart rate 124, SaO2 is 88, ScvO2 is 55. Well, that may be normal because his SaO2 is lower. So you don't really know the answer to either one of these. You've got to have more information. So now we add in more information for patient number 1. He's got a base deficit of 10, negative 10. He's acidotic. His lactic acid, 4.1. He's acidotic. His pH is 7.30. Why the heck does he have an SvO2 of 70%? Because he can't use that oxygen. This is not okay. He has a shift to the left in the face of metabolic acidosis, absolutely deadly. And now my focus has to be, did I over-resuscitate him? Have I got fluid in the interstitium? He can't use oxygen because oxygen doesn't move through all that interstitial edema. Do I need to put him on CRT? Do I need to diurese him? Oh my God, but he's hypotensive. Oh, what am I going to do? I'm calling my attending. He doesn't even understand what I'm saying. Oh my God. This patient, though, is really in trouble. And if all you were looking at is that number, you would never know how much trouble you're in. This trouble tells you what you need to do. We go over here to patient 2. Heart rate 124, arterial SAT 88, ScvO2 is 55. Yes, indeed, he has a base deficit. And yes, indeed, he is also acidotic. The difference, though, is he's still using oxygen. So for this patient, you've got to try to normalize the interstitial space between cells and capillaries, and you have to try to improve the blood flow through the capillary, which might mean you need to reduce his vasopressor. In this patient, all you really need to do is increase his cardiac output, consider giving him red cells, make sure you're controlling fever, make sure you're controlling pain and agitation. And this patient, hopefully, because you are working on him early and aggressively and not charting this number for 4, 5, or 6 hours with profound metabolic acidosis, thinking that this is okay or not doing anything about it, because shortly this patient will become that one. Because over time, he's gotten volume, we have endothelial dysfunction, he leaks fluid into the interstitium, he's going to get significantly worse. Our goal is to prevent you, patient number 2, from becoming patient number 1 by our good therapeutic intervention. All right. So how do you control your patient's oxygenation at the cell? Look for normal SvO2 in the absence of acidosis, and that's what drives your practice. Number 1, always first, always second, always last, always, always. Increase the cardiac output by improving stroke volume, and inotrope. Increase the oxygen content, if possible, by giving packed red cells and increasing the saturation of that arterialized hemoglobin. And then always, always in conjunction, reduce the demand or consumption of oxygen. Control the fever, control the work of breathing. Patient is breathing 30 times a minute on SIMV. Get a grip, put him on ACMB. Don't let him work so hard. As he's working his diaphragm, he's consuming a lot of oxygen. Help that patient, control him, give him sedation, manage his pain, consider paralytics, and assure that he's not having seizures or shivering, which of course are going to cause an inordinate amount of consumption of oxygen. And of course, be sure he's not infected and make sure he's on broad spectrum antibiotics if you have that suspicion. All right, my friends, that was how do you use SvO2 in an effective way at your bedside. I'm going to go ahead and stop my recording.